Hi, it's Michelle with the Medicine Couch, and I'm here today with a special guest who has agreed to tell us a little bit about the specialty she works in. Her name is Trina Lynch, and she has been a PA for 20 years, and most of that has been in dermatology. So she has a wealth of information, and we're going to learn what it's like to really work in dermatology from her. How many patients are you seeing? What's your typical schedule like, days of the week and hours that you work?
Although dermatology may seem, very glamorous from the outside, it's a very hectic schedule. Seasoned dermatology PAs, and we'll see, 30 to 45 patients a day. Sometimes I do know of colleagues who are seeing 60 patients a day, and that's not a lot of time, to actually interact with each patient. It's very sometimes difficult to stay on time or to make sure that you're getting all that information that you need to get to the patient.
What are your typical hours like? What time do you come in? What time do you generally leave? How many days a week do you work?
So I work 4 days a week, 8 to 5, depending on if you're running on time, which usually we aren't. Might have, anywhere from 30 to 15 minutes for lunch. Try to get as much charting done as possible. I usually have about an hour to 2 hours worth of charting to do after work. So when I get off at 5, I come home, do homework with the kids, and do dinner, and then spend a couple of hours still charting. So
do the MAs stay in the appointment with you the whole time?
They do.
Okay.
So they room the patient, and then they come and present to me, and then I will go in the room with the medical assistant, and while I'm doing, say, like a full body skin exam, as I'm going through the skin exam, it's an educational experience for the patient. I'm calling out what I'm seeing and explaining to the patient what those things are that I'm seeing, and educating them on what to be looking for cancerous lesions, what's considered a genetic spot that's non-cancerous, and the medical assistant is documenting on the note exactly where each of those lesions are and whether or not they're benign or potentially cancerous.
So they're kind of act as a scribe in a way as well.
Yes, so they're a scribe as well as helping to perform the procedures.
The MAs are in there scribing for you, but you said that you still at the end of the day have several hours worth of charting that you have to attend to. So what kind of things are you then doing further in the charts?
So going back through each of the charts to make sure, one, that the diagnosis is correct, and that the education that I gave to that patient is documented in there correctly. 2, sending the prescriptions because the medical assistants can't send the prescriptions. 3, going back through path reports and lab reports and reviewing those, and then making sure that those are being communicated to the patient.
For people to get an idea what it's like to really work as a provider in dermatology, or as a PA or an NP, what are the conditions that you see that make up the bulk of your practice?
I think the bulk of what I do on a daily basis are full body skin exams. Having a patient come in and from their scalp to their toes, looking over their skin to make sure that their moles are normal in appearance, being able to identify which ones are suspicious, doing biopsies to remove those to determine if they are indeed, precancerous, and then the other looking for precancerous areas, treating those with cryosurgery. Other conditions that are very common are eczema or atopic dermatitis, psoriasis, warts. That's actually more difficult than people think. It's it's a wart. It should be easy to treat, and patients expect that it's a one and done, and it's not. Warts are very stubborn, and they have to come back for 4 times to have a wart treated. They don't really appreciate that. Acne is another one of the areas that I see a lot of it. I think a lot of people are really affected by their acne in a self-esteem way, and it's forefront whenever you're talking to anyone and you're constantly wondering, having struggled with acne myself, are they looking at that pimple on my cheek? Are they looking at me? Acne, it doesn't go away when you turn 18, and unfortunately insurance companies think it does, so that's always a struggle for adults, trying to treat acne and getting those medications covered. It's getting better. It's definitely come a long way. But yeah, that's one of my passions is treating acne, because I think it changes a trajectory of where a teenager may go. You know, if they're traumatized by bad acne and their self-esteem plummets, you know, they may want to be, you know, an actor or, you know, a public speaker or just someone who's going to be out in front in the public, and choose a profession that they're not going to be as visualized because of those acne scars and so forth. So I really like to, it's very gratifying to be able to help a patient with acne.
What procedures do you do most often on a weekly basis?
Often I never know what's going to come through the door. Obviously with skin checks, you know, I expect to do several biopsies to make sure that, you know, a lesion isn't precancerous or a skin cancer. In addition to that, you know, once we've done those biopsies and we've received that pathology report back, following up on that. So if it does come back as a precancerous mole, you know, doing the excision to remove that, or if we're finding a skin cancer, doing the excision to remove the skin cancer, or if it's a superficial skin cancer, sometimes we can do a procedure that's called an EDNC, which is electrodesiccation and curettage, commonly referred to by patients as the scrape and burn procedure. But those are, you know, some of the things that we do. And of course we have the torture can that patients like to call it, which is the liquid nitrogen, you know, freezing the precancerous areas or freezing warts or seborrheic keratoses. We also have patients who come in, you know, who might have a lipoma that they want removed, or pilar cysts in the scalp, so we'll do those excisions as well. We also do INDs for patients who come in with abscesses. That's actually fairly common, probably 1 or 2 a week. And then, of course, culturing those to make sure that we've put them on the appropriate antibiotic.
And, you know, most people have seen like Dr. Pimple Popper. Are you doing those kind of things?
So, because of the number of patients we're seeing and how quickly, that actually takes quite a bit of time. A lot of times it's the estheticians who are doing the acne surgery or extractions. So because it's time intensive.
Right.
So
that makes sense. Is pharmacology and dermatology generally pretty straightforward, or is it a lot more difficult than people think?
The medications in dermatology are very diverse. There are so many medications in the pipeline, just the number of biologics that are available now to treat psoriasis, and each is just a little bit different. And often insurance companies will require that patients fail other medications like methotrexate before they're able to even go on a biologic. So the pharmacology side of it, you know, it can be difficult, trying to just keep up with all the new medications that are coming out. And then as far as, you know, treating everything with a steroid, yes, we do still use topical steroids, and but even with atopic dermatitis, there are injectable medications now to help with that. And those, again, going back to quality of life, those are game changers.
Do you want to tell people a little bit about what you do on the cosmetic side?
So, you know, a lot of people think, you know, cosmetics is very lucrative. It's not. It's very time intensive. It's also a lot of hand holding with patients, because, you know, you can get a lot of bruising, you can get a lot of swelling, and patients, even though they read about that, they're not necessarily ready for that when it happens to them. So there's that aspect of it. But then the other part of it, you know, goes back to the self-esteem issues. Our society, you know, we place a high value on beauty, and, you know, if it takes, you know, a little bit of Botox or Dysport or, you know, another one of the neurotoxins to help, you know, get rid of a little frown line so someone doesn't look angry all the time, or, you know, just make them feel just a little bit more comfortable in their own skin, then I want to be able to help them. And then you can also use it, you know, to correct deformities. Patient, you know, many people don't even think about, you know, cosmetic dermatology in a medical way, but oftentimes, you know, a patient who's had Bell's palsy, you can use a neurotoxin to help, you know, even, the symmetry with the face, or patients who've had traumatic accidents or who have scarring on their face. There are things that you can do to make those scars less noticeable, or fill acne scars with, with some of the filler products. So it can also be a medical way of helping patients as well.
Are you working with lasers in the office? Are you doing mostly injections? What kind of things do you do?
So I'm not currently working with lasers. I have in the past. Okay. I do a lot of the neurotoxin injections, a lot of the hyaluronic acid filler injections. I do some sclerotherapy, which is injecting the little spider veins to help collapse those so that those aren't visible. I also do microneedling, and use PRP, which is platelet-rich plasma, or PRF, platelet-rich fibrin. And then you can also inject the PRP or the PRF into the scalp for hair restoration.
Oh, okay. So a lot of people may be interested in cosmetic dermatology, or think it's kind of something maybe fun or easier to do. Are there some misconceptions about that, or some things that people need to understand if they want to get into cosmetic dermatology that they may not realize?
Yes. I think a lot of people think that, I can inject, this neurotoxin or do this filler and make a lot of money off of it. And there are a lot of people who are now opening their own practices and going into doing more cosmetics without the real understanding that it's still a medical procedure. It's just because it's considered cosmetic medicine doesn't make it less of a medical procedure. There are incidences of patients being injected with filler directly into an artery that has developed blindness, because that artery communicates with the retinal artery. So unless someone has a very strong foundation in anatomy, I'm talking about going to courses where you're actually doing, facial cadaver dissections and looking at the anatomy and peeling back the musculature to know where to actually place the toxin or where to place the filler, what areas are considered your danger zones and what areas to avoid. Unless you've done something like that, I really don't think people need to be in the industry of cosmetic medicine. I would really stress to patients to make sure that they're doing their research on where they're going, and making sure that the person whom they're seeing is qualified to be doing these injections. Don't just give your money to anyone. Here in the Salado area, there's a new medical cosmetic clinic that's open, Parlor at the Village. There's a nurse practitioner who's been doing ICU medicine for over 10 years and doing cosmetics, as well as a PA who's been practicing for over 20 years, who are both highly skilled in doing injectables, very comfortable and very well trained. And I would encourage that any patient who is looking for any type of cosmetic procedure, make sure that they're going to someone who has, experience and education in that specific area.
So I'm going to leave the link for that business name in the description below if you want to check them out, if you're looking for a really good, reputable place to go in the Salado, Waco, Texas area. Did you know when you first went to PA school that you wanted dermatology as your specialty?
No. I actually thought I was going to be more family practice, rural medicine. The draw for me to dermatology actually occurred while I was in PA school. My younger sister was diagnosed with alopecia areata. Basically, it piqued my interest, and I saw how just kind of devastating it was to my sister from a psychological standpoint. And that wasn't something that was really being addressed in the dermatology world, and that was something that I really wanted to look into more.
I imagine the market was a lot different back,
it
20
was.
years ago than it is now. But how did you find your first job?
Well, this is where that plastic surgery part of it comes into my story. Originally, right out of PA school, I was going to go into a dermatology practice owned by a hospital organization. But from the time I signed my contract, graduated, took my boards, that dermatology practice went out on their own into private practice. And I had been hired by the hospital, and they had no place to put me, so they put me in plastic surgery, which was a great learning experience. And I really am grateful for that opportunity. But again, I wanted to go into dermatology. dermatology.
Okay.
So when my husband graduated from medical school and we went to Utah for his residency, I specifically looked for jobs in dermatology at that point. And I think that plastic surgery background did help me somewhat, but that's where I actually first started my first job in dermatology.
And did they kind of do like on-the-job training with you, or did they kind of expect that you just knew everything when you came in?
I was so blessed. The dermatologist that I accepted the offer from, I got a couple of offers, and this gentleman was just so gracious and so kind and like I said, compassionate, that he was an excellent teacher, and I spent about 3 months just shadowing him before I even started seeing patients on my own. And then we just gradually worked into me seeing more patients. And then as I would see a patient, I would come back and present to him, tell him what I thought the differential diagnosis was, what I thought my treatments were. He would go in with me and either confirm or, say, well, what do you think about this? And do a little bit more education. And every day over lunch, we would sit down and we would pick a topic, and basically we would go through it, and we would spend our lunch hour doing some more education. So it was a wonderful opportunity for me.
Yeah, sounds like a great mentor and teacher.
It was. He was amazing. Still is.
Do you think that happens much anymore today?
I don't. No, not at all. People who are coming into dermatology now, they're asking for people with 2 or more years of experience, and how do you get that? If you've never worked in dermatology, but those are the expectations for on the job postings that I see, and I'm constantly watching those. They want someone who already has a couple of years of experience in dermatology.
So it almost feels like that nowadays, new graduates who really want to get into derm that don't have any kind of connections or any hopes of really, other than blindly finding a job, do you think that they should do residencies?
Absolutely. If that's an opportunity for them, then I think that's a great way to gain that experience. You may not be the primary provider offering that dermatology service. It might be more of a learning experience, but it's experience, and I think you can count that toward your 2 years of experience.
Yeah, and I have seen some ads. They're infrequent, but where a practice is willing to hire somebody for like half the pay for a certain amount of time, whether it's 6 months or a year, as you're training and learning and stuff. Is it worth it in the long run, do you think, to take a situation like that?
I think that's a very difficult question to answer. That has to be, written into the contract in stone, because there's a tendency to keep PAs or NPs at that lower level of pay for a longer period of time. So I think there has to be a finite decision, 6 months and then I go to this salary. Otherwise, I think that we could get easily taken advantage of.
And so you had no kind of dermatology experience before PA school, other than just the general familiarity with dermatology in general. Did you have a rotation for dermatology in school?
I actually did not do a rotation. By the time that I started doing the research for my sister about the alopecia areata, my rotations were already set. So at that point, I wish I had done one. I definitely recommend it, for anyone who's interested in dermatology, but no, I had not done one.
Besides a rotation in dermatology, what other rotations do you think would be most helpful for somebody?
I've been surprised throughout the years about how much internal medicine is actually a part of dermatology. There are a lot of internal diseases that are manifested on the skin, and not knowing and not having that background definitely puts you at a disadvantage when diagnosing or coming up with your differential for some particular disorders. I think internal medicine would be a great rotation. I think psychiatry would also be a wonderful rotation. There's a huge overlap between dermatology and psychiatry. And then other than rotations, trying to do shadowing experiences.
Yeah. So for people who know that they really want to work in dermatology, but either they haven't even started PA school yet, or maybe they're in PA school, besides rotations, is there anything else that you can recommend that they do to try to get more experience or to make themselves a better candidate?
There are, multiple organizations affiliated with all the different autoimmune disorders, like the National Alopecia Areata Foundation, the National Psoriasis Foundation. I think becoming members of those organizations, and not just being members, but actually interacting with patients who have the disease so that you hear their side of the story to make you a more empathetic provider is crucial. Because again, I just cannot stress enough the psychological impact that these diseases have on patients. I think having that understanding of where the patient's coming from helps you to be a better provider.
Okay. And I guess that would go for anybody who's already a PA or NP working in a different specialty, wanting to transition to dermatology. Getting involved with those societies is a good place to start as well. Correct?
Absolutely. Not only that, but there are the Society of Dermatology PAs. That's a great organization to be involved with. You don't have to be a dermatology PA working with the board certified dermatologist to attend those conferences, but certainly going to those conferences definitely helps, to learn about the field. They do like a little boot camp prior to the actual main conference, and that's a good way to get your feet wet.
So is that boot camp, is it like hands-on learning skills, or is it more just learning about specific topics in dermatology? It
depends from year to year. Some years there are actual courses that you can take where you learn how to do punch biopsies or shave biopsies, or where you learn how to use a dermatoscope to look at a mole up close to determine if you feel like it needs to be biopsied. They sometimes offer cosmetic courses that are not necessarily hands-on, but where you're watching another provider so that you can get more information to see if that's something that you're interested in. And then there's obviously that didactic component to it as well.
Right. And then I'm sure there's a lot of networking that can happen there.
Yes,
too.
Absolutely. Although with COVID, that has been, the virtual, it's not as exact, it's not as great, but yes, there's a lot of networking. And a lot of times dermatology seems to be one of those coveted professions where everyone wants to work in it. It's a lot of fun. It's very rewarding, but those jobs tend to go fast, and they tend to go to the people who, already know someone who's interested in it or has a little bit of experience.
Right. Some things I've always heard about, what's great about dermatology is there's no emergencies in dermatology. There's not call, like you aren't going to be working holidays, and that people, even if their insurance won't pay for it, they will always fork out the money if it has to do with their look stuff. Are these stereotypes true?
I think there are emergencies in dermatology, absolutely. There are medications that can have, significant side effects. A lot of the more serious dermatology diagnoses aren't done in the private practice setting. Those are handled in hospital facilities or practices associated with medical schools or teaching hospitals. Outside of that, of those hospital situations, and your general dermatology practice doesn't typically, have a call schedule. There is a after-hours number that they can call if they have a problem, but as far as doing a call rotation, there's not one.
So how independently do PAs and NPs usually work in outpatient dermatology?
I think it varies based on location. I think a lot of PAs and NPs are more likely to work in rural areas, so therefore there's a lot of autonomy. I think you need multiple years of experience before you're doing that. You also need to be able to have your resources, your physicians that you can contact if you do have a question.
But even if you're working in an office that has multiple physicians, for the most part, is the APPs, they're seeing their own patient panels, right?
Absolutely, rarely, do you have to grab one of the physicians or dermatologists, to ask a question. We're doing a lot of it on our own.
There's a lot of great things in dermatology that people may not realize, like we just talked about. What are some of the downsides, do you think, of working in dermatology?
I think it's becoming way more difficult as a dermatology PA, and not just a PA, an NP, and even the dermatologist, with private equity buying up these dermatology practices, because dermatology is a lot of procedure based, and up until just this past year, most of the reimbursement was based on procedures. That has changed, and it'll be interesting to see how that affects private equity acquisition of dermatology practices. But when you start putting a dollar sign on a patient and that money becomes more important than the care of that patient, that to me is a hard stop. And I don't think that business has a place in medicine, and I don't want my ability to take care of a patient to be hindered by mandates from someone who has no medical experience.
What kind of things are you seeing? Is the amount of patients they want you to see, or do you feel like there's pressure now to do procedures that you may not feel like is necessary? What are your thoughts on that?
There's a little bit of both. Definitely an increase in the number of patients, especially with the changes in the reimbursement and how we're documenting and how we're coding this past year. We are definitely having, that subtle, suggestion that, maybe you should code it this way, or you should do it this way, or see more patients, and that just doesn't benefit the patient, and that's not a fair way to practice medicine. And I'm not in favor of private equity ownership of medical practices.
Any other downsides that you want to cover?
Sometimes we do have patients who come in who are looking for specific treatments that they've read about or heard about on television that they feel like is right for them that aren't, because of either underlying diseases that they have, or, contraindications because of other medications that they're on, that we have to talk through that with the patient. And sometimes they're very adamant that, no, I want this. This is what, everyone says works. And you can't please everyone. And yes, sometimes there are those very demanding patients, whether it's a medical dermatology patient or a cosmetic dermatology patient, that unfortunately you just have to say, I'm not the right provider for you.
What resources do you think are really good for people to use who work in dermatology? Either they're just starting out, or if they want to work in dermatology and they're trying to gather up their resources?
I think that anyone who wants to work in dermatology needs to be very familiar with how to look at a lesion through a dermatoscope. It definitely increases our ability to recognize a potentially scary lesion, precancerous versus melanoma. It decreases the number of biopsies that we do because we're able to look at it on a more magnified level. If you're going to be in dermatology, you have to be very comfortable with using a dermatoscope. There are courses that you can, courses specific to dermoscopy that you can go to. There's one put on by Mayo that is in Arizona every year, and I think that's a great one. There's a website out of New Zealand, DermNetNZ, and .org, I believe, and I use it all the time.
One of the hardest things is to describe the lesion accurately, and I found that site actually has like the refresher and pictures on like how you describe things. So, if I haven't done that in a while, I go to there really quick and I'm like, oh yeah, that's what that's called, or that's how I describe that.
The terminology.
It's just great for that. It's a very visual site too.
It is. So
that's really helpful. But one of the cautions about it that people have to think about is that because it's New Zealand, some of the medications they talk about are not FDA approved and can't use in the U.S., so you need to go to Hippocrates or somewhere else like that to verify what medications are available.
Correct, yes.
In the U.S. to use.
There's Visual Diagnosis, which is a great dermatology app that you can download on your phone. You can enter in the type of lesion, the location, the age of the patient, whether it's widespread, acute, chronic, and it'll give you a list of differentials. The other nice thing about Visual Diagnoses, similar to some of the other apps out there, is that as you're looking, through these these different diagnoses and reading on them, it is also logging the fact that you are going through them. So you can actually get Category 1 CME with these apps as well.
Yeah.
There is another app. It's MOS, AUC, Appropriate Use Criteria. You can use that app to determine whether or not the lesion that you've biopsied needs to be referred out to a Mohs surgeon, or if that's something that can be done in your office.
Okay. Do you think there's a personality type that's suited for derm, or aspects of personalities that do better in dermatology than others?
I think you have to be compassionate. I really do. Again, I don't want to sound like I'm just really going back to this over and over, but there are so many patients who come in, who have been struggling with lifelong chronic skin disorders, who self-esteem is just really, really low. And you have to recognize that, and you have to be empathetic.
Yeah, I can imagine how much of an impact you must have on someone's life, and how good it feels as a provider to know that you might have potentially changed somebody's whole course of their life. You may even actually save their life. Their self-esteem is so bad if their acne doesn't get cleared up that they, especially as teenagers, can have suicidal thoughts, and to be able to prevent that and to change how they feel about themselves must be pretty rewarding and gratifying.
It's incredibly rewarding having that patient come through the first time and not being able to look you in the eye, and having their hair covering their face, and then being able to treat them, and 3 months later they come back and they've got a new hairstyle and sporting makeup and talking about hanging out with their friends and having a boyfriend or a girlfriend. It really gets you.
Is that probably one of your favorite things about working in dermatology?
It is. Yeah. Absolutely. Sorry.
No, it's okay.
Hey, I just, having struggled with it myself, and not having been able to actually, take any medication for acne until I was in college, I know what it did to me. And for anyone else to have to feel that pain and have to struggle with that, to be able to prevent that for them is my ultimate goal. Yeah, absolutely.
That's awesome. So I just want to say thank you, Trina, for taking your time to tell us about dermatology. You may not know all the different ins and outs of that specialty, so this has, I think, helped people a lot, and I appreciate you taking the time.
I'm very happy to do that. Thank you for reaching out and allowing me to share my experience.
Very useful information, so thank you again.
You're welcome.